Perfect. Thank you very much. Good afternoon, everyone. Welcome to this webinar entitled Journey to Remission, Transforming Type 2 Diabetes Management. My name is John Mathers, and I have the privilege of chairing this afternoon's webinar. Also joining us today are Professor Eileen Gibney from University College Dublin, Professor Roy Taylor from the University of Newcastle, and Professor Susan Jebb from the University of Oxford. Professors Taylor and Jebb will be our speakers this afternoon, and after they've given their talks, then we will have a discussion which I will chair. So the program is pretty simple. I'm going to make a few opening remarks, and then Eileen will tell you a little more about HDHL, Healthy Diet, Healthy Life, and then we'll move straight into the webinar proper. So Eileen, could I invite you to make a few remarks about Healthy Diet, Healthy Life? Thank you very much.
Great. Thank you, John. And it's lovely to be here to chat about Healthy Diet, Healthy Life. So I go on to the next slide. So for those of you that don't know me, my name is Eileen Gibney and I'm Professor of Nutrition at University College Dublin, but my role here is as Chair of HDHL, and really it's for me, really important to continue to ensure that as a community of researchers, of policymakers, and those active in the area of food and health, really ensure that we remember there is a very close link between food and health, and this is something that we need to remind ourselves as we go forward in our research, in our policy, and in our careers. Next slide. So then in terms of Healthy Diet, Healthy Life, this is really the core of what the Healthy Diet, Healthy Life network is about, and it's a community of representatives from ministries and funding organisations across Europe who have this link between diet and health at its core, and it brings together these actors in food and nutrition where we can consider the key challenges in a collaborative and impactful manner to drive change in our food system with a positive impact on health. It's been operating for about 15 years and it brings together resources to fund research, align national priorities. It's hosted and supported by ZON-NW. We also have advisory boards with key scientific voices and other stakeholders. And our focus is on that interdisciplinarity that is needed to deepen the evidence base to support policy and have positive change. So we have three core areas of activity: think tanks, research, and exchange forums. And within the think tank, it's about expert advice, guided discussions, addressing challenges, and really having those hard conversations. Through our funders, we also then fund research, and that is that transdisciplinary approach to generate the new knowledge that is needed to support and underpin societal change and policy for particular areas. And then we have exchange forum to help support and strengthen the collaboration, knowledge, etc. within those. So next slide, please. So as I said, we lead and advocate in activities that bridge through food and health through those four activities. We're involved in a number of partnerships such as Food for Health, Clever Food, Food Pass, etc. And we lead in discussions and try to advocate for the linkages between food and health in future funding programs in our European funding framework. We also support early career networks and support the development and leadership of future leaders and the next generation within those. So we're a very busy network, a very busy activity, trying to advocate keeping health at the core of those food and health discussions. And that's why we run things like these webinars and other activities. So we have had a previous webinar, so next slide, please, which was all about diabetes prevention, where the speakers you can see there talked about prevention at a community level, national programs, and then particular focused on community groups. And that previously recorded webinar is available on our website. You can see the link that we have there. So although prevention is key, we do know that it won't solve everything. So we do have to then look at, the next step, which is what we're going to address today. So next slide, please. And I'm not going to spend too much time on this because I know John is going to further introduce, but today we're going to talk about the remission side of things. So that full journey of looking at both prevention and then, you know, if individuals do progress into suffering from diabetes, that we can then bring those back through strategies that address remission. So really looking forward to hearing today what everything is about, and just want to say thank you and welcome to everybody. Appreciate the time and effort that everybody has come here, particularly our speakers, but also you attending, and I hope you learn lots today. Thank you.
Thank you very much, Eileen. That was an excellent introduction to HDHL. So just a few words from me to set the scene for this afternoon's webinar. Diabetes continues to be a growing problem around the globe. It's growing particularly rapidly in some low and middle income countries, and it's linked with changes in lifestyle. And until about 20 years ago, it was assumed that if one was diagnosed with type 2 diabetes, which is by far the most common type of diabetes, that was a diagnosis for life. Now, initially, studies in people who had undergone bariatric surgery, now sometimes called metabolic surgery, showed a loss of their diabetic features. And so the idea began to emerge that perhaps type 2 diabetes was not a diagnosis for life. And since then, work looking at diet and other aspects of lifestyle have shown is that certainly type 2 diabetes, for those who've been diagnosed, say within the last 5 or 6 years, can be put into remission. And that we're going to be talking about some of those issues this afternoon. And I'm delighted now to say a little bit more about our speakers. So our first speaker will be Professor Roy Taylor, who is the Emeritus Professor of Medicine and Metabolism at the University of Newcastle. Roy is a diabetologist and has worked clinically for most of his career. He was also the director of the Magnetic Resonance Imaging Centre in Newcastle. And the great focus of his research has been on understanding what goes wrong, what are the metabolic problems that cause the disease we call diabetes. And over the last 10 years or so, perhaps 15 years now, Roy has been preeminent in studies to work on the remission of type 2 diabetes. So Roy, without further ado, I invite you to give your presentation.
Thank you, John. Well, one screen. Well, good afternoon, ladies and gentlemen. I'm speaking to you from Newcastle upon Tyne, and here is a view of Newcastle. This is our fine Newcastle, where the city got its name from. That was back in 1186 or thereabouts, and you can see how these names stick. And some other things stick around as well. Type 2 diabetes as a heterogeneous disease. That title, heterogeneous, has stuck and is widely believed it's a mysterious condition with lots of different causes in lots of different people. And that's very strange, because this is the commonest metabolic disease in our species, shared across the mammalian kingdom and some others. So how can we really understand? Here are my disclosures, which are not relevant to the lecture, and I'll cut straight to the early studies. In the first 20 years or so of my career, I was really interested in what happened to food after we swallowed it. All the attention tends to be on the food on our plate that we eat, but in fact, it's the liver that decides what the body sees. Because that absorbed food goes up the portal vein, much of it remains in the liver. But we started off looking also at type 2 diabetes and applying magnetic resonance to be able to measure muscle glycogen directly. And we observed that after meals, a person without diabetes, on average, would put about 30% of their meal carbohydrate into muscle by 5 hours after a meal. That was a peak. But in people with type 2 diabetes, there is a complete failure to do this. this is the practical consequence of insulin resistance in muscle, which, remember, is the first detectable risk factor for type 2 diabetes. If you have insulin resistance, it doesn't mean you're going to get it. It just means you're likely to develop it if other circumstances apply. But if glucose absorbed from food isn't stored as glycogen, only part of it can be oxidized. We can only absorb so much energy, and of course that's very useful in the 2 hours or so after a meal. But if it's not oxidized or stored, there's only one pathway which can take it. That's turning the glucose into fat for storage. Happens only in the liver and produces only 100% saturated fat. So it's a pathway to watch. But fat in the liver causes insulin resistance, and that was quite a shocking and striking finding when first made. And entirely separately, quite a long time ago, Roger Unger demonstrated elegantly that chronic exposure of islets to fat caused loss of glucose-sensitive insulin production. Not just any old islets, because if they were taken from rats that would not develop diabetes genetically, even if overfed, these islets were resistant to fat. This is the level at which there's an off-on switch, yes-no, for developing type 2 diabetes. Don't forget that 3/4 of the people with BMI over 40 do not have type 2 diabetes. But all those factors fed into putting things together in 2006. It took 2 years to publish the hypothesis, but it was actually precipitated by what John referred to. There was a paper reporting bariatric surgery and the remarkable disappearance of diabetes. And this paper suggested that that was due to incretins that were produced in excess from the gut once people had had the surgery. And I read the paper carefully and laughed out loud because it was quite impossible. It could not have been the incretins. The surgical procedure was ileopancreatic bypass. After that extensive procedure, nil by mouth for 7 days, as written in the methods section of the paper. The authors were pointing to fasting plasma glucose on day 7 and saying, well, it was due to the postprandial spikes in incretins. It's not true. And indeed, we've been able to demonstrate directly that the postprandial spikes are irrelevant to the improvement. What is happening is sudden induction of negative calorie balance. Could it be done by diet? Well, putting things together, it seemed to me that positive calorie balance was necessary as a step to type 2 diabetes. That might cause a liver fat to start building up. But if there's insulin resistance, then this process of glucose into fat is going to be expediting this and leading to a vicious cycle. Because liver fat causes liver insulin resistance, glucose production won't be restrained, and that will cause a slight tendency for plasma glucose to creep up, immediately slapped down by basal insulin. And it's a fact of life that insulin stimulates this process. So you see, we have a vicious cycle slowly grinding on over many years. And above a certain point, the liver fat just doesn't stay there, but is going to increase the normal level of production of fat to provide energy for the rest of the body. It comes out as a lipoprotein, very low density lipoprotein, and it delivers triglyceride around the body. But this is the link with the pancreas, because the plasma of the LDL should deliver fat for storage to the subcutaneous adipose tissue. If that site is relatively replete, then it has to go somewhere else, and it will expose all the tissues to higher concentrations. So the poor old beta cells are exposed to excess fat, just like Roger Unger's in vitro experiment. And we can conceptualize a pancreas cycle. In those people with susceptible beta cells, about 1/3 of people of white European ethnicity, about half people with South Asian ethnicity, then this susceptibility will be expressed as decreased insulin response to food eventually. And that, of course, will cause plasma glucose to rise. It's easy to put these two cycles together and see that we're dealing with a liver cycle, a pancreas cycle, but this is the driver, positive calorie balance. So let's reverse that and see what happened. And that was the driving force behind the first major study of this sequence, the counterpoint study. It was a hypothesis testing study. Now, we were predicting such a huge effect that we could say yes or no to the hypothesis with a very small number of people. There's a belief abroad that studies have to be big to be believable. And indeed, we ran into this when we published. But in fact, the smaller the study, to get significance with a pre-planned hypothesis, the greater the effect size. How could we get the negative calorie balance? Well, this is the diet I devised having listened to my patients. A chronic burden of deciding what to eat, how much to eat. Well, let's just have a packet for each meal. And then the total quantity. The old studies, 40s and 50s, 1940s, 1950s, really showed very clearly that below 1,000 calories a day, hunger was relatively subdued. So let's go for less than 1,000. And of course, we need to keep the bowel happy, so good roughage with non-starchy vegetables. This is what we used in Counterpoint, and these are the results for the glucose, plummeting down, despite stopping all hypoglycemic agents on day 1. Stop the drugs, cure the diabetes. And of course, about 700 kilocalories per day was started. The mean weight loss at 8 weeks was 15.3 kilograms. That may sound excessive, but don't forget, with an average weight gain of half a kilogram a year, people aged 60 have put on a very considerable amount of weight. And our average age, I think, was about 52 in this study. So this is what happened in this group of people with short duration diabetes. Let me just show you one item that is interesting visually. That is our magnetic resonance measure of liver fat. Now, we were using magnetic resonance, not as an off-the-shelf measure, but developing new techniques to be able to directly measure the biochemistry in internal organs. And we could visualize this by putting every pixel showing the concentration of fat in that point in space on a color chart. And this nasty blue-green of the liver, which is this large organ almost filling the upper abdomen, showed that we were 36% liver fat in this individual, unknown to have a liver problem, just ordinary type 2 diabetes. And at 8 weeks, 2%. Reduction of food intake brings about the biggest metabolic change in any parameter in respect of liver fat. But this is one subject. How about the average? Well, the average came zonking down. The mean for the non-diabetic control group is shown here. These were relatively chubby people, and so the liver fat was just about 8%, but way up there in type 2 diabetes, and after weight loss, coming down enormously. Glucose control, reflected by the average HbA1c measurement, was normalized in 2 months. Don't forget that it takes 2 months for this slow juggernaut to turn around. Getting into the normal range at 2 months is remarkable. The plasma triglycerides fell to normal. Now, triglycerides are the joker in the pack for clinical diabetes. We tend to ignore them because hitherto there's not been any drug, any move we could do to reduce plasma triglycerides. And so pull the shutters down, ignore them. Well, we don't have to ignore them anymore because we can deal with them. How about the pancreas cycle? Well, liver fat was significantly high and fell significantly. Did it induce an increase of first phase insulin response? Yes, it did. Not completely to normal, but sufficient to restore normal overall control. Now, the counterpoint study unleashed a wave of interest and a wave of criticism. It's too small. Hang on, it's a hypothesis testing study. Look at all the stars along here. We've demonstrated the hypothesis has not been disproved. We've demonstrated it's likely to be true. But of course, this was carried out, all these post-tests were carried out during the 700 calorie per day diet. Well, the question was raised, surely when people go back to eating, everything's going to come back. The diabetes hasn't really gone away. We know that diabetes is for life and it gets steadily worse. Again, a belief. Well, to do this job, we started on a second study. And we measured, once again, first phase insulin secretion, and I show it here after the 8 weeks of diet, but also after 2 weeks of refeeding. And then after 6 months of normal living. They were contacted on a couple of occasions to try and encourage them to keep their weight steady. Weight remained absolutely steady. The first phase insulin response remained absolutely solid, as did all the glucose parameters. So the counterbalance study, Diabetes Care, not published till 2016 due to being rejected by many journals, as new ideas often are. This was the first demonstration that this reversal of type 2 is durable, and we were looking at remission, which is a word that carries a time base with it. It's a long-term affair. And it was the early data from Counterbalance that persuaded Diabetes UK to fund a major study, the DIRECT study. And this randomized control study asked the question of whether primary care nurses could achieve remission in most all comers just by having 8 hours of structured training on how to do it. Well, we gave the training, ran the study, nearly 300 people were randomized, 149 to the weight loss program of rapid weight loss, careful stepped return to normal eating, and then encouragement to keep weight steady, or NICE guidelines, the best management we thought. And at 1 year, 46% were in remission. The practice nurses and some dietitians in Scotland had achieved exactly what we had wanted in a surprisingly large number of people, because I had thought, and we had powered the study, on getting 22% remission. That's what we thought would be clinically useful. But understanding type 2 diabetes was what we saw in our tightly controlled studies going to happen in primary care. Well, liver fat was very high and came down. Fasting glucose came zonking down. The form of triglyceride that is actually produced directly by the liver, the VLDL triglyceride, came down to normal, and pancreas fell, and guess what? Acute insulin response was restored. This is type 2 diabetes. It's a condition of too much fat inside liver and pancreas. Very simple to grasp, and in fact, in the early years, able to achieve remission. I didn't point it out going past, but the counterbalance study was a study of dose ranging for duration of diabetes. That's where the 6-year limit came from, the counterbalance study, because in the first 6 years, the remission rate was really rather good and fell off sharply after that. But we followed up the DIRECT cohort for 5 years. Now, the word of mouth was rapid weight loss is always followed by rapid weight gain. That's a nonsense catechism that only relates to failure of adequate weight loss in the first place and also failure of some follow-up. In the intervention cohort, the weight was still 6.1 kilograms below baseline. So that was okay, not enough to achieve remission in most, but just remember that the DIRECT was designed to be feasible to roll out in the British NHS system. So people were reviewed by the practice nurse at regular intervals. That's all. So getting 6.1 kilograms off at 5 years, and of course much more in the previous 5 years, was a big deal. Remission, 13%. Now people look at that and say, oh, that's disappointing. Hang on a minute. Who were those 13%? Well, it won't surprise you to know that these were the people who avoided weight gain. They stayed in remission. So with more precise follow-up, more targeted efforts to keep weight off, this can doubtless be improved. There was concern, especially amongst dietitians, that rapid weight loss would be harmful. There's no evidence for that, none at all, but it was widely believed it might be bad. Well, there was indeed a significant difference in the serious adverse events, defined as enough to cause hospital admission. And on our intention to treat analysis, if you were randomized to the intervention group, you halved your risk of being in hospital in the next 5 years. The benefits are huge. This was made up with a mixture of conditions, quite a lot of serious infections, and also quite a lot of cancers. In the controls, there was exactly the number of cancers that would be expected, type 2 diabetes followed over 5 years. In other words, 8. In the intervention, there was 1. A similar trend has been reported in bariatric surgery, but this is information that needs to get out there, and people need to be appraised of the dangers of carrying around this excess weight. Now, DIRECT wasn't big enough or long enough to determine any cardiovascular outcomes. So we looked at the proxy, the Q risk or 10-year cardiovascular risk score before and after 1 year. And in men, nearly 15% down to 8, in women, 10 down to 6. And this is the age and weight matched equivalent. You can see that people were going back to a level that was not significantly different from having no diabetes at all. Remarkable data, and indeed borne out by a retrospective analysis of the look-ahead study, which showed that this is exactly what happens in real life, with a total of 49% decrease in cardiovascular events over a course of 12 years, even if remission only lasted a few years. But let me finish up with a concept that's really rather important. This clearly is all a matter about weight. Which of these 3 men has type 2 diabetes? Well, you'd be prompted to say, well, yes, this one, maybe that one, probably not. Hang on, let's consider how they come to be here. These 40-year-old men looked like this when they were 20. We have a cross-country runner there on the left. We have a rugby player on the right. They have all put on an equivalent percentage body weight. Could it be that there's a threshold for individuals to develop their type 2 diabetes? Now, this idea came about by looking at all our data across Counterpoint all the way through to Direct, and seeing that people with a BMI of 27, the lower range of what was recruited, responded exactly the same as people with a BMI of 45, which was the upper limit for this study. If they lost 3 BMI units or thereabouts, the diabetes went away and the pathophysiology was identical. So how about these apparently thin people with type 2 diabetes? And we looked at that in Retune. Weight loss in people with type 2 diabetes and BMI 21 to 27. And you can see here what happened. Liver fat, all the changes as you would expect. And the insulin secretion is a less impressive rise, but we were forced to use a much less precise method of measuring it, hence the wide error bars on this graph. So the pathophysiology of people who have genuine type 2 diabetes but are a low weight is exactly the same as heavier. They need to lose weight within the normal range. That's a concept that we need to roll out into clinical practice. coupled with the thought that we do need to remember diagnosis, because we're talking about type 2 diabetes here. We screened the population recruited to direct for monogenic diabetes and type 1. 16% in this weight range had one or other. So we do need to be cautious about diagnosis. But the nature of type 2 diabetes is quite clear, especially when we consider that this slim group of people had 70% remission of type 2 diabetes, having lost a median threshold of 6.5% weight loss. Wide range of individual personal fat thresholds. So we can see clearly type 2 diabetes is a condition of fatty liver, which causes increased VLDL secretion, very low density lipoprotein, cholesterol on the outside, triglyceride on the inside. This elevates cardiovascular risk and induces beta cell dysfunction in susceptibles. It's not this causing that, it's a matter of the central abnormality of type 2 diabetes, raising both. With weight loss, the normal liver fat allows normalization of this, normalization of these. That is such an important concept to grasp. Now, because I'm often asked about the details of how this rapid weight loss program works, there's information on our university website here. It's also written up in this book, All Royalties to Diabetes UK. It's not a commercial advert. Which is a readable book for people with diabetes, but also written with an eye to inform doctors, nutritionists, dietitians. So that takes us down to the River Tyne, and staring into these dark inky waters, I wonder if you would agree with me when we see these conclusions. Type 2 diabetes is a state of high secretion of VLDL from the liver due to excess intrahepatic fat. And remission is achieved by correction of this excess, to be achieved by substantial weight loss. And although this could be done by any means, bariatric surgery, GLP-1 agonists, you name it, other dietary approaches, to achieve this in large numbers of people, the rapid weight loss program is the only evidence-based method of bringing home the bacon. Thank you.
Thank you very much, Roy. That was excellent. So can I ask that anyone has questions for Roy, please put them into the Q&A. I see there's already one question in there, and we'll have a look at those when we get to the end of the second presentation. So Roy, thank you very much, but don't go away. We'll need you at the end for the Q&A. So I'm now delighted to welcome our second speaker, Professor Susan Jebb from the University of Oxford. Susan is the Professor of Diet and Population Health at Oxford, and she's also the Chair of the Food Standards Agency. Throughout her career, Susan's been very interested in many problems associated with obesity, both the risk of developing obesity and how to prevent that risk, particularly through changing diet. And a feature of her research career has been the development of randomized controlled trials, particularly those carried out in primary care. So Susan, we're delighted to have you here this afternoon, and I invite you to give your presentation.
Thank you very much indeed. It's great to join you all today, and thank you very much to Roy for giving such a great background into the sort of physiology of type 2 diabetes, and particularly the opportunities for remission. I want to move now into talking a little bit more about the applied, more clinical aspects of this, and I'll finish up with some suggestions about where I think this field is going. So I think it's always really important to start with the people who are affected by type 2 diabetes and to ask, what is it that they are really looking for in research? It's very easy as researchers for us to get carried away with what we think is important, but what matters to people who are affected by this condition. So when we do a whole range of different engagement events and dialogues with patients, the same points come up over and over again. Can this ever be cured? what can I do? And in particular, which diet should I follow? People have an innate sense that actually their diet matters to their diabetes. And how much weight do I need to lose to stop my diabetes medication? I think the message that you are at higher risk of developing type 2 diabetes if you're overweight is now well established. So people then instantly turn to, well, how much do I need to lose to make this all go away? And the direct trial, as Roy showed, really was the first time that we'd seen that a dietary intervention could lead to successful remission. So direct used a total diet replacement approach. What it showed is that successful weight loss is really the strongest predictor of remission. And this is the data at 2 years. And what you see very, very clearly is that people losing 10 kilos of weight, or 10 or more kilos of weight, more than half achieve remission. And indeed, for patients who lose more than 15 kilos, you'd be a little bit unlucky if you didn't put your diabetes into remission. It is a remarkably effective treatment. But of course, saying this is highly effective, we shouldn't underestimate the challenge that it is for patients to be able to lose what are quite substantial amounts of weight. Nonetheless, the success of this total diet replacement approach has been adopted into routine healthcare policy in England, where we have a programme called Path to Remission, which enables everybody who has been recently diagnosed with diabetes, that's up to 6 years from diagnosis, to access a total diet replacement programme together with behavioural support. So patients are encouraged to have total diet replacement for about 8 weeks, followed by 4 weeks of reintroduction of foods and further behavioural support for 12 months. They're referred by their healthcare practitioners to a private total diet replacement provider. And that support is provided either individually or in groups. It might be face-to-face or it might be provided remotely. What we see is that the uptake is actually a bit lower than we would like it to be. It's hard to know exactly what proportion of eligible patients say yes, but it's probably of the order of 15 to 20%. So it's relatively low. And even beyond that, the uptake amongst people from ethnic minority groups is significantly lower than it is for the white majority population. Of those people who start the programme, just over half complete it. And if we look at retention, which of course is so important for getting good outcomes, what we see is that retention in the programme is lower in more deprived areas. And so you're beginning to see why, although this overall is a successful programme, it does introduce some inequity into the system, because we get lower uptake from ethnic minority groups and lower adherence from people in more deprived areas. I'll come back to that later. But among completers, those people who do go on to successfully complete the programme, they get outcomes which are broadly in line with what the direct trial showed. The average weight loss is about 9.4 kilos, and a third of people achieve remission. Interestingly, those who achieve remission actually have an average weight loss of almost 16 kilos. It's perhaps better to look at this in these graphs, and this shows you on the left-hand side the amount of weight that people will lose, and you can see that the first 5 months really corresponds to the total diet replacement period, and as people then start reintroducing food, there tends to be a little bit of rebound in their weight, which then on average settles out over the course of 12 months. But what you can see from the error bars is there is a fair amount of inter-individual heterogeneity there. On the right-hand side, you see the graph, which is very like the one I showed from direct earlier. But what I think is evident is the proportion of patients who achieve remission is slightly lower at any given weight loss than we saw in the trial. And the reasons for that are not entirely clear. So here, people who've lost more than 10 kilos have, 10 to 15 kilos, they have a 34% chance of being in remission, whereas in the direct trial, it was 45%. But once again, once you've lost more than 15 kilos, then actually the remission rates go up significantly. But here it goes up to about 55%, and that's compared with 83% in direct. And the reasons why it's lower are not clear, but may be related to the type of patients. Remember, this is being rolled out in routine care, and it's a much more heterogeneous population than those who were recruited in the trial. Ooh. Sorry, I've rather messed up this animation here, so you can't see it terribly well. But one of the things we wanted to pick up on was this idea of what is it that patients want, because we see that although total diet replacement programs are very effective, actually only 15 to 20% of eligible patients take them up. And so when we talk to people with type 2 diabetes about their experiences and their expectation of treatment programs, we did a number of one-to-one interviews and focus groups, as well as some more informal discussions at public engagement events. And one message came through more clearly than anything else. That was this: people want to eat real food. Many, many people simply did not find the idea of having these specially formulated and very nutritious, nutritionally complete soups and shakes. They did not find that an appealing prospect. They wanted to eat real food. And this was enough to deter many people from trying the program and to deter some others from continuing with it because they really missed the absence of real food. We particularly found when we talked to people from ethnic minority communities that they felt that total diet replacements were simply not consistent with their cultural habits and their way of eating, which had a much stronger social and family dimension than we see in all of the white majority population. We went on to do a discrete choice experiment to try to understand this a little bit more, to try to identify the preferred features of a weight loss program. So here the experiment included nearly 4,000 adults who were living with obesity in the UK. Some of them had type 2 diabetes, but not all. The single message here was that total diet replacement was the least popular of all the options. I should say that partial meal replacement was significantly more popular than total diet replacement. And so this might involve people having 1 or 2 soups and shakes a day, but also crucially having some real food as well. And what you can see in the data presented here is that basically anything else was better than total diet replacement. In fact, interestingly, calorie counting came up as the most popular option. But we were also interested in the fact that low carbohydrate diets, the idea of cutting out a single food group, had some appeal to patients. And this is an idea which has gained an increasing amount of attention in recent years. So how could low carbohydrates diet work? And I think this is particularly interesting and important when we're thinking about the idea of diabetes remission. So Roy has already given you a lot more detail about the physiology of insulin secretion and glycemic control. So I'm not going to spend time on it here, but I think you'll accept that there is at least a plausible theoretical basis why low carbohydrate diets might be particularly helpful for people with type 2 diabetes by reducing the demand for insulin on the beta cells. We are running a program, an experiment in Oxford at the moment to look at the long glycemic control. And this is data just from the very first patient that's gone into this experiment. And this is the results from wearing a continuous glucose monitor for 2 single days. The first during the baseline period, and the second when they were advised to adopt a low carbohydrate diet, but maintaining the calories the same. So this is not a weight loss diet. This is keeping weight the same. We're looking here specifically at the effect of removing carbohydrate from the diet. And what you can very, very easily see is that you get a much more stable glycemic profile, removing not only those periods of hyperglycemia, but also periods where there is some evidence of hypoglycemia. And in England at least, and perhaps in other parts of Europe too, the idea of low carbohydrate diets for people with type 2 diabetes has gained quite a bit of traction. And there are a number of GP practices, family doctors, who have become quite keen on this approach. This is data from one practice in the northwest of England, run by somebody called David Unwin. And David has been a particular champion for a low carbohydrate approach. This is data from a clinical audit in his practice. So this is it's not a trial, it's not even a formal cohort. This is looking at data from a proportion of people in his practice, about 27%, who persisted with a low carb diet. And what you can see is that amongst these people, even though his recommendation is low carb without any particular calorie restriction, people who persist with this approach do tend to lose weight. And so the average reduction was from almost 100 kilos down to 91. And at the same time, we see that these people achieve much, much better glycemic control. So HbA1c fell from 65 to 48 millimoles per mole. And 46% of patients were in remission from their type 2 diabetes. And you can see a little bit more detail in the bottom left of the remission rates. So this diagram, again, very similar to the one that Roy showed. And what you can see is for patients who are losing 10 to 20 kilos, there's about a 50% chance of being in remission. On the right, bottom right, there's just some data from the prescriptions that were issued from the practice in comparison to other comparator practices. And what you can see is that their prescribing of drugs to treat diabetes is substantially lower. So this is all, as I say, audit data, but nonetheless, it begins to build up a case that for people who are prepared to persist with a low-carb diet, there may be some benefits, and this may be an option for diabetes remission. But and so perhaps unsurprisingly, there's been growing enthusiasm for this in the press. But what does the trial data show us? Well, this was a nice systematic review that was published in the BMJ a few years ago. And this looked firstly at body weight after 6 months on people advised to follow a low-carb diet in comparison to a higher carbohydrate control. You can see a certain amount of variability, but overall there was a significantly greater weight, a lower weight in people after the low-carb diet, about 3.5 kilos lower than those on the high carbohydrate diet. However, at 12 months, there was no significant difference in weight, suggesting perhaps that the low-carb diet had brought forward some weight loss that would have occurred anyway. Nonetheless, I don't think we should rule out that early initial weight loss can be quite motivating for some patients. What happened to glycemic control? Well, this is the data for diabetes remission. Before we look at the data, I should just say this is quite a loose definition of remission, because it was remission measured at a single point in time and simply looked at whether HbA1c was less than 6.5%. I'm sorry to keep jumping units in relation to explaining HbA1c, but it reflects what was used in the different papers. But what you can see is with this slightly loose definition, there does appear to be a benefit of low-carb diets with slightly higher proportions of patients who are achieving remission. But once again, there was no significant difference at 12 months. And that suggests to me that they're not getting sustained remission in people who are following low carbohydrate diets. Now, when you look at these individual studies in a bit more detail, one thing becomes very clear, particularly if you're a nutrition scientist, and that is sometimes the carbohydrate reduction was not really what we'd call low carb at all. It was, in some cases, only down to about 40% of calories from carb. And of course, typical intakes, certainly in the UK, are about 45%. So that's a very, very small reduction. And secondly, even if there was an early reduction in carbohydrate intake, that was rarely sustained over time. So at least part of the lack of efficacy at 12 months is probably down to poor adherence to the diet. So if low carb has potential, we've got to find ways of making it easier for people to continue these diets for longer. And we're also going to have to find a way of being able to deploy this in routine care. As you can see in this slide, if you look at the numbers of people involved in any of these studies, they're extremely small. These are research trials which have generally been led by specialist staff in research centres. But if we want to make this a viable treatment in routine care, we're going to have to develop an intervention which is suitable for generalist staff to deliver. So where had we got to, and this is maybe a year ago, the state of the art on lower carb diets? Well, randomized trials show greater improvements in glycemia than higher carbohydrate diets, but at 6 months, but with no difference at 1 year. Modest reductions in body weight at 6 months, no difference at 1 year. Some reports of remission amongst patients who highly engage and persist with these programs, but it's just not clear whether this is acceptable to a wider group of people, whether it can be delivered at scale by general practitioners. And actually, we don't have any evidence about the long-term impact on cardiovascular risk. And that's important because people are concerned that reducing carbohydrate may lead people to having a diet which is much higher in saturated fat and also higher in protein, particularly animal protein, which might have adverse cardiovascular effects. So we set about trying to address some of these evidence gaps in our team in Oxford, and we developed a programme called Diamond, Dietary Approaches to the Management of Type 2 Diabetes. This was essentially a low-energy, low-carbohydrate diet. And what we were really trying to do was to take all of the benefits of total diet replacement, but also to take on board the lessons we'd heard from patients that they wanted real food. So we aimed to reduce energy intake to about 800 to 1,000 calories per day. And if we can get people to cut out carbohydrates, that's actually a really good way of cutting out a lot of calories, because almost half of our calories are from carbohydrate anyway, but also because carbohydrates tend to act as a vehicle for other calories. So most people, for example, would put butter on their bread. So if you take out the bread, you remove the calories from that butter as well. Instead, we wanted to really put the emphasis on people eating fresh, healthy foods, if you like, a sort of Mediterranean type diet approach, although we didn't call it that. And we recognised that in order to make dietary change stick, people need a lot of behavioural support. If we look at what happened in total diet replacement programmes, what patients tell us over and over again is that actually it's the support which sits alongside the meal replacements which really helps them to succeed. And so we designed a programme which could be delivered by generalist practitioners without any specialist nutrition training and in a moderate amount of time. So as you can see, it involved 1 GP appointment for 10 minutes, which was basically to motivate patients that this was important treatment for their diabetes and to, if necessary, adjust their medication. And then 5 appointments over the course of the next 6 months with a practice nurse. We developed a mass of patient resources so that patients had something to rely on at home, and also, frankly, to help the practice nurses to be able to deliver the intervention. So there was a support guide with hints and tips about what to eat. There was recipe books and specifically catering for different ethnic groups and different styles of eating. And we encouraged patients to monitor their blood glucose at home, because we think that that can be quite motivating for patients and provide a form of biofeedback about their adherence to the diet. We initially ran a feasibility trial, and this was done by Liz Morris, who's a GP and clinical PhD student in our team. We wanted to see whether we could deliver this intervention and whether patients would accept it. On each of our feasibility criteria, we were really, really pleased with the results, because 100% of people who were willing to attempt the dietary intervention after randomization. That's important because, as I showed previously, many people don't want to attempt total diet replacement. We saw that practice nurses were able to deliver the intervention with high fidelity, and we defined fidelity as delivering at least 60% of what we considered the essential elements of the programme. And crucially, for the purposes of a trial, we were delighted that 100% of participants attended the final follow-up session. On the back of this, we felt that we were justified in going forward to a larger trial. This was only about feasibility, but of course we couldn't resist just looking at what had happened to their body weight and their blood sugar levels, remembering, of course, that this is a relatively small group. What we saw were very strong evidence of promising clinical outcomes. Patients had lost almost 10 kilos, and I should say this is the most successful weight loss intervention delivered by a practice nurse that we've ever seen before across all of the trials we've done previously. And there was a really marked reduction in HbA1c of over 16 millimoles per mole. So on the back of that, we've gone on to plan a big definitive trial. I very much wish I could tell you the results, but we don't have them just yet, although they're coming soon. But you can read the protocol in Contemporary Clinical Trials. In brief, it's a cluster randomized trial, including over 600 patients. These are people with type 2 diabetes of less than 6 years duration who are also living with obesity, closely following the inclusion criteria for DIRECT. It involves 12 weeks of a food-based, low-energy, low-carb diet, and the comparison is usual care for people with diabetes. People get ongoing support for a further 4 weeks afterwards, and the aim of that period is to allow people to reintroduce some unrefined carbohydrate into their diet, putting the emphasis on high fibre and whole grain sources. And the primary outcome is diabetes remission at 1 year. We've adopted a very, very stringent definition of remission, and that is that patients have to have an HbA1c less than 48 millimoles per litre on 2 occasions, at least 6 months apart, and off medication. And that reflected the international consensus at the time we developed the protocol. As I said, we've now completely finished the study. We're sort of midway through the analysis, but this is the kind of patients that we recruited. We intentionally set out to look at a very, very general population sample. So we specifically targeted practices in a way which allowed us to recruit people across the full range of deprivation. And so you can see the quintiles of IMD here, and you'll see we got a very, very good spread. We also had 18% of people who were of non-white ethnicity, again, reflecting the UK population. People were typically in their mid-50s. They weighed around about 100 kilos. They'd had diabetes for almost 3 years, and they had a starting HbA1c of 55. We're really excited about and we recruited, you can see in the top corner, from right across the UK. We are really excited about what this might show, and because although we don't have I can't share the final results, the qualitative evidence from both patients and practitioners was extremely positive. People found this, nurses found it easy to provide people with this kind of information. Patients found it easy to follow, and many of them reported that they had got very positive benefits from it. So where do I think we are with remission? Well, we need to be realistic and say total diet replacements are still the only dietary treatment that's proven to lead to a significant increase in rates of sustained remission at the present time. What Direct told us is that weight loss is the strongest predictor of remission. And that would suggest if you can achieve weight loss, you probably will achieve remission. And there'll likely be a relatively direct relationship between those two things. We're currently awaiting the outcome of trials of other interventions, including low carbohydrate diets. And I think in today's world, we also have to recognize that the weight loss associated with the new anti-obesity medications is in the range which is likely to be associated with remission. I think the caveat is that this weight loss is unlikely to be sustained without ongoing medication. And then the question comes is, does this actually meet the criteria for remission if you're taking treatments which are in themselves designed for glycemic control? And that, I think, is a bit of a challenge for us as sort of clinical academics in thinking, what do we actually mean by remission? And I continually go back to what patients said to us at the very start of all of this, which is for them, treating their diabetes was about coming off medication. And I'm not sure how many of them want to replace one drug treatment with another. So just finally, what are we thinking about the future research and clinical priorities? I think the most important thing, and this is happening already, is that the treatment paradigm for diabetes has really changed. We're moving away from just managing this condition to actually thinking about remission, particularly when patients are first diagnosed. I think there's a real issue about how can we increase the acceptability and in particular the equitable uptake of total diet replacements, which are a very, very effective treatment. How can we encourage more people to give it a go? Because actually what we find is when people try it, the initial weight loss is sufficiently good that it's very motivating. So in fact, it's more successful than people think it will be. But clearly, we need to co-design and test other dietary approaches for weight loss and glycemic controls in diverse populations, recognizing the concerns that have been expressed by some groups about these sort of soup and shake type diets, particularly in this era where people are worrying about ultra-processed food. There's a huge appeal to eating natural, fresh products. I mentioned already about sustaining weight loss, and that's particularly true after pharmacotherapy. We've got a review, a systematic review, which we presented at the European Congress on Obesity earlier in the year, showing that of the 15 kilos of weight that's typically lost with pharmacotherapy, that is regained within 18 months after coming off it. That is much faster than the weight regain after dietary treatments alone. But nonetheless, even after dietary interventions, we have to recognize that people struggle to maintain weight loss. And then finally, I think the key point which is really driving our research is not just about looking at individual treatments, but actually thinking about how can we offer the right treatment or the best treatment at the right time for individual patients so that we can maximize the proportion achieving remission. At the moment, we tend to refer patients to one program, and if it's not suitable for them, they fall out of the system. Instead, what we think we need is a much more adaptive approach to the management of type 2 diabetes. In fact, we had a program called New Dawn, where we were trying to develop this new adaptive weight management program, which allowed patients to try a number of different approaches to try to find the right diet for them. We did a lot of development work. We were very, very excited by it. But in the end, we actually had to close the trial. The only time I've ever had to close a trial early in all my career. But we had to close the trial because we simply couldn't get the healthcare system to be able to adapt to delivering this much more complex and adaptive pathway. But that, I think, is something that's a real challenge for how we deliver care. How do we get the right treatment to the right patient at the right time? Thank you.
Susan, thank you very much. That was excellent. There's several things that I will probably come back to in a moment, but just hang on because I just want to make a comment to ask people if they've got questions for Susan or for Roy to put them into the Q&A. There are already several questions in there, and I'll come to those in just a moment. But I'd just like to open by asking Roy about this problem of duration of diabetes. Both you, Roy, and I think Susan have referred to people who've been diagnosed, say, up to 6 years since the initial diagnosis of diabetes. What about people who've had a diagnosis for longer? Are they kind of out of it? Is there no hope for those people?
That's a really important question, John. I'd say right away that there are some individuals with 23 years duration of type 2 diabetes who've come off 2 agents and have achieved lasting remission. So it's not impossible, and it's very clear to me that some people have islets that are relatively resilient. In other words, they batten down the hatches with a fat attack, but when that goes away, they can recover. So some people, but if we look at all people with a duration over 20 years of type 2 diabetes, my guess is that we'll be looking at remission in 4 or 5%. So it falls off, it doesn't go away. Why do we decide on the 6 years? It's all about economics, regrettably. To get the health service to pay attention, this has to be really cost effective. And that's a very reasonable point, and it's become even more reasonable as the years go by. And so with 6 years duration, as you saw from the data that Susan presented, we can get well over 80% of people into remission if they lose sufficient weight. So that's the origin of the 6 years. But for the person in front of you, if they want to do it, and many people do, then yes, suck it and see. If they lose weight, they'll get huge cardiovascular benefit anyway. All the liver changes will be achieved. That's important to emphasize. The liver will go back to normal. VLDL will go back to normal. The beta cells are the problem. They're the ones that fail as time goes by in susceptible people. Thank you.
Thank you, Roy. And would you expect for those individuals who've had long-term diabetes, even if they couldn't go into diabetes remission, would their cardiovascular risk have improved? So would they have got other benefits beyond diabetes?
Yes, and I can tell you that with data from the counterbalance study. We demonstrated that the cardiovascular risk in this non-responding group was actually higher at baseline, and it fell substantially. I can't remember the exact numbers, but it was something like 19% down to 15%, whereas the people in remission were very similar to direct. They went from about 15% down to 7%. So really important point. There is benefit. Weight loss is always a good thing. And remember what most people told me? I feel 10 years younger. That's something that people actually want.
Thank you very much, Roy. Susan, could I just turn to ask you a little bit more about the experience so far with the NHS path to remission? And clearly there's some encouraging news there, but also some real problems. And I particularly like to focus in on the issues around equity. And it looks as if there's a bit of a problem in getting people to take up the offer of this pathway. And I wonder if you know where the problem sits. Does it sit with the patients or does it sit with the healthcare professionals? What's the issue?
I think it's difficult to know, and I very much doubt there's one single answer. I suspect that doctors are not necessarily approaching everybody who might possibly benefit from this, because I think there's always a temptation for us to decide on people's behalf that this probably isn't suitable for you, or now isn't a good time to talk about weight loss. I've certainly had some doctors say to me that they feel patients have enough to deal with in coming to terms with their diabetes without having to go on this very intensive diet. So I suspect that not everybody is being offered. I worry too that the expectations or impressions or anecdotal feelings amongst some health professionals are not hugely positive about total diet replacements, and that might mean that they don't present it in an optimal way. Now, we could overcome that with training. And also we know that when healthcare professionals start getting feedback from their patients, then they start to develop a more positive response. But there will also be some patients who just think, no, this isn't for me. So I know that there are some who don't perceive that they need such a what they perceive as a very intensive, drastic approach, and so they will say, "Oh, but I don't need to lose that much weight." And I think that for them, they may need different approaches. So I think there's a whole mix of reasons, but we should not underestimate how valuable this program is. It's valuable for the thousands of patients who are already benefiting and who continue to benefit from it. It's valuable in terms of focusing people's minds on remission as being an achievable option. And remember, even those who don't achieve remission are going to get lots of benefits. They're going to get improved glycemic control. And it's stimulated this whole raft of other research where we're now looking to say, what are the other complementary options that we can use? So it's not perfect, but we're very, very fortunate to have this program running in the UK.
Just a very quick point about the ethnic mix. In direct, we found that the recruitment, which was delivered by trained enthusiastic practice nurses, was every bit as good in the low socioeconomic areas, and we have the lowest in one of our local practices here in Newcastle, as in Sonny Pontylan, the high practice. However, the dropout rate was moderately greater in the lower areas, but the people who stayed in the programme achieved exactly the same remission rates. Over time, they found it more difficult to sustain the weight loss. So yes, the social determinants of health, as Marmot pointed out, are just so important.
Thank you very much, Roy. We've had discussion about total diet replacement, about low carbohydrate diets, but we have a question about whether some people with type 2 diabetes might benefit from a higher protein diet, protein-rich diet. Susan or Roy, any thoughts on that?
So there's certainly, physiological reasons to think that might be helpful, and that protein might help stimulate insulin secretion. And Roy could comment more on that. The lower carb diets do tend to be proportionally higher in protein. Maybe not if you go for a low energy, low carb diet. Of course, the absolute amount of protein is lower. But if you look at what David Unwin was recommending, which wasn't necessarily low energy, then you do tend to get slightly higher protein. There's also been a suggestion that for older people, it may be helpful to have higher protein diets. But I'm going to let Roy talk about the physiology of it.
Yes, I don't think dietary protein will affect the beta cell function. The ranges are very different from, for instance, we use the response to amino acids to actually do part of our insulin stress test, secretion test. So no, not that. Protein is quite satisfying, and so as a component of the diet, that's important, but it's probably not going to make a huge difference unless, of course, people are relatively protein deficient. So we can't assume that everyone is eating the sort of mix of nutrients we expect them to be eating. So there is a real point there. Yes, they need to be on an adequate diet. I've yet to see data about aging and increasing protein increase that makes any difference. But of course, the change in muscle mass, which we haven't touched upon, can be offset entirely by resistance exercise, but is not necessary. The tiny, tiny change in genuine muscle mass is a reflection of the decreased daily workload every time you stand up, every time you climb stairs. So your muscle mass comes down.
Thank you very much. Sustainability of remission is clearly a challenge. And Roy, you referred to the issue that at 5 years in the direct trial, only a proportion of those who had been in remission earlier were still in remission. And one of the questions we've had is, do you think repeats of the rapid weight loss diet intervention at, say, 2-year intervals could prevent relapse?
Yes, it could do, but I'd introduce a caveat here. We use the reintroduction of the low-calorie diet as a rescue package, because one of the challenges of keeping weight down is not a drive to appetite. It's not what the average group line suggests. It's the fact that people run into life events. You have financial problems. They take over your whole thoughts for the time being, and you forget about the focus on food, your weight goes up. It's a very human thing, and we've got to understand that. I was shocked how often it happened to our general practice population in direct. And so we introduced rescue packages, which was use of the low-calorie diet to bring them down. 50% of people in direct needed them. It's one of the least quoted items about direct. So 2 points. Yes, they will work again, but no, repeated use is not that popular. People don't particularly want to go back to it, but some modification of it, as Susan's hinted at, would be entirely acceptable.
Great, thank you very much. Could I just go back to Susan about her comment at the very last bullet point, I think it was, about making sure you've got the right intervention for the right person at the right time, which seemed to hint at some kind of personalization of management. And I'm just wondering, given the pressures that healthcare professionals are under, is that really going to be feasible? How would it work in practice?
Well, those are challenges. What we proposed in New Dawn was really two concepts. One is that we probably should be thinking about having specialist weight management hubs rather than expecting. I mean, I always fall back to GPs because I work in a department of primary care, but rather than expecting GPs to know every single different weight management program that's available in their area, which frankly changes every 5 minutes, and they all have different inclusion criteria, they have a different form to fill in, and so on. It puts real friction in the system for them to actually work out what's the right program for this patient. So I have this idea that they would simply refer them to a specialist weight management hub rather than doing it themselves. And then you'd have somebody in the hub who doesn't need to be medically qualified, perhaps, but there's a sort of governance process around it, who would help to direct the patients to the right program for them. But I think the second element is, all of the research has shown it's incredibly hard to predict upfront who is going to do well on which treatment. Really, really hard. The best predictor of success is not really a predictor at all. It's about weight loss in the first couple of weeks. So what I have in mind is that the hub would point somebody to what we think is the most effective program, probably in the first instance, total diet replacements. But rather than the notion that we currently have is, well, you know, here you go, this is it. You actually say, look, give it a go. Would you be willing to give this a go for a couple of weeks and see how you get on? I think that becomes a much more attractive offer. You're not committed to it forever. And then you say, if this isn't working for you in a couple of weeks, then we'll think again. Don't worry, we've got another approach we can try. And that was really the whole basis of New Dawn, that we firstly recognize that this won't suit everybody, that we reframe a treatment not working, not as being you haven't stuck to it, which I'm afraid has been the tradition, that, you know, oh, every diet works, it's just people who fail. Let's reframe that. We, health professionals, did not find the right treatment for you, so give us a chance to have another go. But what that then hinges on is us having other credible programs. So I think that, you know, personalization at the minute, and frankly, is a bit of a suck it and see, because as academics, we just don't know what's best for which person. We've been remarkably unsuccessful, really, in the personalised nutrition arena. So I think it's about giving it a go.
Could I just make a couple of points? Susan, you referred in your talk to the low uptake in direct. That's not actually true. We recruited direct by a cold calling letter from the GP to suitable patients in the practice. Usually that elicits an average of 6% people who step forward and volunteer. In direct, it resulted in 28%, a huge number. That's manyfold over what most people would do to sign up to very frequent visits to the doctor, lots of extra blood tests, it was a big deal. And so we got 28% on that. And we know that some 40% of people would have liked to have done it, but just didn't want to do it. So this is a one size fits all, a sort of practical NHS aimed thing that could feasibly be delivered. And in people with diabetes, and I'd emphasize that, with the idea of trying to, as you say, get off medications. People want to be demedicalized. It's really very attractive, and they will go to considerable lengths to change their habits in order to do that.
I hope I didn't say anything about the uptake in direct because I didn't know what that was, but certainly in the NHS England programme, we think it's around 15 to 20%.
Yeah, yeah. Although, to be fair, all the funded places are taken up. Maybe I shouldn't say that too loudly, but it is running as hard as it can do, dealing with this impossible tide of problems.
Agree. I'm a supporter of it, not a critic, but
Sure.
we constantly challenge ourselves to how we can do it better and reach more people. See, one of the other issues and one of the potential appeals of the low carb approach is that it will be a lot cheaper to deliver than total diet replacement. So but we need to see if it works first. So I want to remain very measured about this because I think we need to be sure it works first.
There's a really important point, if I could make it. You showed the very impressive data from David Unwin. You didn't say what his secret magic was. He personally weighs everybody in the clinic and asks their permission to discuss their weight with them. So it's not true they weren't getting weight reduction advice. They're under huge pressure from a fabulous GP. He is charismatic. And the effect of that personal weighing by the man in charge was amazing. And I know because I've actually been advising on David's papers all the way through from the very first one. So this is
I agree. And that's why we need a trial. That's why we need the trial, because we want to see whether a low carb diet, when it's not done by David Unwin, when it's done by an overworked doctor on a wet Wednesday, actually still works.
Excellent. So let me go back to the Q&A, and we have a number of other questions. And there's one about adverse effects. And Roy, I think you'd said that there were no serious adverse effects in the direct trial, but one of the participants in the webinars said, well, what about less severe health complications? Was there any difference in this, the other adverse effects that didn't get you into hospital?
No, absolutely not. And this is borne out by the NHS England programme, because looking at the whole range, there was intense sensitivity to not running into a big problem of causing some unspotted hazard. And no, there's not. There is none. Although in the same breath, I would mention that, yes, in the first few days, headache is occasionally found. Most people report increased energy levels after 1 to 2 weeks. Quite remarkable. They're bounding around the place, released of their burden. But about 1 in 20 people does report feeling a bit tired in the first period of time. So those are points to make. And also sometimes telogen effluvium, just a temporary loss of hair that you get with any serious illness, pregnancy, metabolic stress, that goes completely back to normal in due course. So those are the 3 issues I'd mention. I suppose I have to mention constipation as well, which is why I continue to favour the inclusion of the non-starchy vegetables as real food. As Susan hinted, people do like crunch, they do like eating, and the non-starchy vegetables seem to at least partially sort that.
Thank you very much, Roy. And for Susan, someone's just asked about quality of life on low carb diets. So do you have any information on how quality of life?
We will have. We've certainly collected that information. I have to say, though, that my experience in measuring quality of life in other weight loss trials is that the usual scales we use are pretty insensitive. You know, they're not really designed, the question's not really designed for the sort of more subtle shifts in quality of life that you get with weight loss. They're more designed for people who, you know, now can see again, or you know, they've got much more dramatic improvements. However, the systematic reviews which have looked at the impact on quality of life of weight loss do see that you get small improvements, not huge, but small but measurable improvements with weight loss. And I would expect that to be the same, but we will have that data from our trial.
And that's exactly what we reported in Counterbalance and in Direct. And at 5 years, that improvement in quality of life was maintained.
Thank you very much. And now the last question we have time for is around alcohol. So we live in a society where alcohol consumption is pretty normal, and it can supply 5% or so of energy in most people's diets. Do we need to do something about alcohol consumption in these kinds of diabetes remission programs?
Yes, we need to advise people that to undergo the process, the A to B journey of losing weight, please don't drink. Now, we had one participant who said, look, I just love my Friday evening glass of red wine. I would like to carry on. And so we said, okay, but you know, you need to be very strict with yourself in other regards. He actually lost over 20 kilograms because he stuck with it. So, you know, in moderation, it's there, but I just use that as an exception, because during the weight loss, no, and in the long term, people have to be reminded, pint of beer, 200 calories, it's extraordinary. A gin and tonic poured at home, about the same. You know, it really is a huge calorie intake that people don't see because it's transparent. So really important to consider. I'm sure I'm really speaking for you, Sue. Here it's
most people who drink alcohol would be better if they drank less alcohol, and that's true whether you've got diabetes or not. But I think the issue is, as Roy says, in relation to weight loss, we know that liquid calories, whether they're alcohol or not, are less satiating than solid calories. And my other phrase that I often remind patients is that willpower is soluble in alcohol. So you may be able to resist some snacks when you're sober, but suddenly that greasy sausage roll seems like a good idea when you've had a few drinks. So best avoided, but that's easier said than done for many people.
Wonderful advice to end up with. So Susan, Roy, thank you both very much for an excellent webinar. This has been recorded and it will be available on the HDHL website for those of you who would like to have a look at it again. So just leaves me to thank all of you who've joined the webinar this afternoon. And Susan and Roy, super. Thank you very much indeed. Have a good evening.
Oh, yeah.
Bye now.
Bye-bye.